Greetings, everyone. Thank you for joining us. I'm very fortunate and excited to introduce Dr. Adina Blickstein. She joined us a few months ago, and I was already intrigued with some of her insights. So I look forward to the more we have to learn from her. And I noticed that there's a lot of child-trained people here, so I think we'll all appreciate your insight. Dr. Blickstein is an MD and also has her MPH. She's a holistic child psychiatrist specializing in integrated energy therapy in child psychiatry. She's done her fellowship at Westchester Medical Center and had a master's in public health from Columbia. She focuses on repairing, enhancing, and creating sustainable, flourishing, and mutually beneficial parent-child relationships. Oh my goodness, that sounds so good. We all need so much of that right now, I feel. Dr. Blickstein will present her research on the protocol, the TiRAT protocol, trauma-informed relational attunement training. That's aimed at training physicians, parents, and educators and attunement skills proven to enhance resilience and reduce mental health symptoms in children and adolescents. She's the CEO and founder of Teal Dragon Healing, an integrative pediatric psychiatry practice in Stamford, Connecticut, where she applies her expertise in her practice specializing in the reunification of alienated parents and their children. And she spends her time raising two adolescent boys, so it sounds like a lot of this is not just theoretical, but practical as well, in Stamford, and her partner and stepchildren and stepdog in Boston, Massachusetts. So with that, I'll hand it over to Dr. Blickstein. Pleasure to.
So this is me. Yes, thank you for the beautiful introduction. My name is Dr. Adina Blickstein. I'm a child adolescent psychiatrist, founder and CEO of Teal Dragon Healing. We are a transformational company for family healing and reunification. Among other things, besides traditional med management and psychiatric evaluations, one of our programs is called the Family Reunification Program, where we pull families out of high conflict divorce in which children are triangulated, and we have them decide whether they want to continue destroying their family and fighting or reunify their family and heal. And so within this work, we work with a lot of guardians of the children. Our primary interest is the behavioral and mental health of the child. And so our goals for the family, when I say reunification, is not getting a parents back together to get married, rather having them become amicable business co-parents in which they can amicably parent in the healthiest, most productive way so that their child doesn't have to suffer and be a victim of triangulation. And when we see retrospectively the mental health and adverse childhood experiences, ACEs, divorce, and high conflict divorce is a huge, huge risk factor for later development of severe behavioral health issues, including psychosis, which in my opinion is an extreme form of stress reaction. So we really strongly believe in this work. The families that have chosen to reunify have all successfully reunified, as we're very strict about our boundaries and signing our reunification contracts. But when you really sit down with people and you ask them, like, are you invested in your child's mental health? And the answer is yes, then the answer is clear. We need to stop conflict. Okay. So that's just a little background. One of the ways I use the TiRAT protocol in my reunification cases, as well as my reunification cases that don't involve high conflict divorce. Reunification can involve parents that just want to get closer to their children. They're not in high conflict divorce. Maybe they have some fights with their spouse. Maybe they don't. Maybe their relationship with their partner is fantastic. They just want to become closer with their child. And so parental alienation is more common than we think. Parental alienation means a parent is simply not close to their child. They don't feel connected enough. They don't feel like they're getting the relationship they deserve as a parent. And that's parental alienation. And it could be that the child comes home from school and they're on their phones for 5 hours. That's alienation. And we want to get parents and child to love each other and be mushy and huggy and just as a family is supposed to be. So Teal Dragon, this is like a beautiful image that I did from artificial intelligence. And it's all about power and love. And that's what we're all about. We're about power and we're about love. And a lot of people think that when we're loving, we're giving up our power. And when we're powerful, we're giving up our love. That is not true. That is not true. That is a myth. We can be powerful, we can be loving, and they're not conflictual, and they don't have to be opposing ends. And unfortunately, a lot of parents think that if they give up their power and their control, they're going to be stepped over. And if they're just too lovey, they're permissive. And we just dispel all those myths about what we've been conditioned as parents and what empowered parenting really is. It's another heart because I like hearts. Okay, so this is me, child adolescent psychiatrist. I have a master's in public health and maternal child health. I'm an integrated energy therapist, and I founded and created this protocol called trauma-informed relational attunement training. So I'm going to break that down for everybody. And I want to just give a little background that in child psychiatry, we like to label children. We like to label them with anxiety disorders and depressive disorders and thought disorders. And I thought it was only fair that if we label children, we need to label parents. So I've coined a term called relational attunement disorder, RAD, because I found that the kids who have these diagnoses have parents with relational attunement disorders. Now, it's not in the DSM, but when I worked with parents on the TiRAT protocol, which is relational attunement training, and I teach parents how to reverse their attunement disorder. Of course, I'm labeling in a playful way, but sometimes being humbled by the realization that you cannot attune or you're having difficulty attuning is what propels a person to grow and say, you know what? I need to learn how to attune. That's my problem. Kids aren't alienated for nothing. Kids are alienated because they're not feeling attuned to. And it's the job of parents to attune to kids. And so therefore, most parents who come to me, I would say 96%, I'm always going to leave those parents who are attuning great, but the majority of parents who come to me have relational attunement disorder, and they have difficulty understanding the needs of their child and communicating that those needs are understood. And those are the reasons for the child acting out in ways that manifest in behavioral dysregulation, anxiety disorders, and aggression. So we need to really focus here on how we can train and help parents, and not just parents, but how we can train and help providers, pediatricians, psychologists, teachers to appropriately and healthily attune. One of the issues in blocking attunement is our personal childhood trauma. If we have not been attuned to as children, we will naturally not be able to attune, simply because we haven't been attuned to. In the reverse, if we were attuned to as children, we will be able to attune. However, I break down the word attunement into really explainable parts so people can understand and learn how to attune, even if they weren't attuned to as children. Okay, this is a lot of words. It's really a copy of my abstract with our protocol that we tested in a sample size, of a very small sample size, to gather data. And I'll just read it out loud. I know it's a lot of words. So trauma-informed relational attunement training shows efficacy in treatment of mental health systems across all ages and all diagnoses, improving the relational environment of designated patients, shows great promise in improving mental illness. So I want to talk about the relational environment for a moment, because I know that's a new concept. So relational environment means the environment in which the child lives relationally. How toxic is the environment? How positive is the environment? What environments do children exist in? Home and school. So the relationship environment involves the relationship with the relationship dynamics, energy flow within the home, and the relationship dynamics and flow within the school. This treatment targeted relational dynamics of parents and kids in the home, although we are expanding our studies to relational environments in the school setting. So just a little background: mental health issues persist, necessitating urgent attention to prevent negative consequences. Current interventions targeting designated patients have seen limited success due to continuous interaction with environments reinforcing negative mental health patterns. So I want to address that when I initially started my practice, I was functioning like any traditional psychiatrist and offering medications. Now, these kids were going back into dysfunctional relational environments, such as home and school, and everything I did became just obsolete and regressed back. It is nearly impossible to treat a child in isolation. And this is why focusing on targeting relational environments has shown such efficacious results. And it's so unbelievably promising because there's no regression. In fact, when parents are trained and teachers and educators are trained, there's only sustainable and improving results over time. And so this research is asking us to question how we're even practicing child psychiatry and why we're targeting a child as the designated patient. Recent efforts addressing relational environments have shown promise, yet quantifiable improvements in psychosymptomatology remain unexplored. In response, we initiated a study to assess if focusing on the closest relationship interaction of symptomatic patients could enhance both symptoms and overall relationship, leading to improved resilience. Okay. So let me just go through the details of this protocol and what we did. So we had 5 patients in this data gathering study or initial data gathering group, and they consist of children and young adults diagnosed with generalized anxiety disorder, OCD, dysregulated mood disorder, DMDD, conduct disorder, ADHD, and ASD. So they were across the spectrum of mental illness diagnoses. We also called this protocol child-centered parent training, a colloquial term for parents when we market the program, but from a research-oriented perspective, it's known as trauma-informed relational attunement training. And it consists of 6 to 12 sessions once a week via Zoom live with me, focusing on skills, teaching parents child attunement, co-emotional processing, validation of patient experiences, which I'll go through the curriculum in a moment. Weekly 1-hour classes were conducted via Zoom, and parents provided pre and post intervention assessments of their child's symptoms, their assessment of their parent-child relationship, their own levels of confidence in general as a parent, their own levels of hopelessness, and their own levels of frustration. So just to summarize, surveys were not given to children. Surveys were given to parents. They offered pre-post surveys of how stressed out they were in relation to how they did as parents, how frustrated they were, how hopeless they were, and levels were very, very high. When parents come to me, they are totally at their wits' end. They're like, I don't know what to do. I'm going crazy. I'm hopeless. I've lost my confidence. I'm completely frustrated. My kid's going bonkers, or my kid's totally isolative, or my kid's anxious, right? So across all diagnoses, we had patients. This is just a screenshot of an example of our rating. So here it's called PT, Parenting Effectiveness Training, but it's essentially an example of one of the forms. So the childhood depression, anxiety, tantrum pre and before, and then this was the pre, before, and this was after. Okay, so this is just an example of the form we used. So before was 7, high, after was lower, 5 and 5, and the confidence was still the same. I don't remember if this was after 6 weeks or 12 weeks. Before was depression 3, child anxiety 3, tantrums 3, and after was 2, still the same, anxiety and tantrums 5. The totals don't matter here. But this was just an example of the forms we gave out, and then we graphed everything. So I'm going to talk about the results, but let me just go over the curriculum and the intervention. Essentially, it is 6 weeks. There's 2 parts. It's level 1 is 6 weeks. Level 2 is 6 weeks. Basically, section 1 is the fix-it parent, learning what it means to be a fix-it parent and how parents try to fix their kids because they think their kid is broken. And that's why they come bring them to the psychiatrist. What's wrong? Fix my child. So understanding that that's totally delusional because nobody can fix anybody and we cannot control other human beings. And to have a fix-it approach is actually counterproductive, right? And we go into that in more detail in the class, but a lot of we label this idea of fix-it parent And it really comes from parental inadequacy, a deep sense of feeling like they don't know what they're doing. And this is why they're really feeling the need to control their child. We talk about empathy and perspective, codependency, help-seeking behavior, parental askability. Again, not going to go into details of the training, but these are the topics that we address. The second 6 weeks is balancing the family, understanding rupture and repair, what it means to have a healthy relationship, what is the anatomy of a healthy relationship, and we lower expectations, and we explain that health is not about everyone jumping up and down and smiling and all the time like rainbow butterflies. Rupture and repair are fundamental aspects of relationships, and the key to health is how fast you can repair, and the nature and the way repair is done, and the speed and manner in which repair happens determines resilience, relational resilience, as well as an individual's resilience. And so we learn how to repair when there's a fight, when there's a disagreement. Healthy anger. What is healthy anger? I teach something called anger alchemy, which is understanding the energetics of unhealthy anger. Just briefly, unhealthy anger is spread out energy. It doesn't go anywhere. It causes a lot of dysfunction and disruption. And healthy anger could really create inspired action and could lead to positive change. The analogy I give is, imagine a rocket ship with fire inside the ship, the rocket ship, which would destroy the rocket ship, versus fire under the rocket ship, which propels the rocket ship. And those are examples I give of how to alchemize our anger. And it becomes a very powerful tool then to actually propel healthy relationships forward. I use an activation practice, which I call dragon yoga, which I also incorporate into this training, which I teach people how to use voice and movement to get their anger into their power. And it's a grounding technique. We could go into that a little later if you're interested in learning some. The role of parents. What are we supposed to be doing? Why do we have kids? This is more of a spiritual and existential exploration, but it is very important. We talk about parental adequacy and how really truly adequate do we feel as parents, and we have people get really vulnerable. And then emotional decoding and active listening. And so this is the intervention, and let's just see the results. So post-intervention, children showed improvements in depression, anxiety, and tantrums across all subjects, positive changes in parental perceptions, including increased confidence, and improved parent-child relationships were observed, with reduced hopelessness and frustration. I did pull out the exact data. It's a little hard to read, but basically with our subjects, we have tantrum started from 8 and went to 5. Frustration started at 9 and went to 5, and the confidence increased from 3 to 5. GAD, the anxiety went down from 6 to 3, frustration 3 to 1, hopelessness 4 to 1, confidence 5 to 9. This parental competence. DMDD, we had tantrums went from 10 to 3, frustration 10 to 2, hopelessness 10 to 2, confidence 3 to 8. ASD is anxiety went from 7 to 5 to 5. These are the people that did the 12 weeks. So that's why there's 3 measures. Tantrums 8 to 1. I think we just missed this data point. Frustration 10 to 5 to 3. Hopelessness 10 to 5 to 3, which is extremely, huge is an improvement. And confidence 3 to 5 to 6. And then a 9-year-old with GAD, we had anxiety went from 7.74, 7.54, frustration 10.53, and hopelessness in the parents went down from 10 to 4, confidence went up from 0 to 6. So let's just look at the subjective reports. So it has given me a set of tools to implement new ways of communicating, more aligned with how I approach a business negotiation, allow me to be more effective in supporting my child in high emotion situations, help me improve my relationship with my son, a lot less conflict, more independent, strategies to handle specific situations, hopeful that things can change, starting to build more confidence as a parent. Help me better understand my child, what he wants, not being able to escalate, tantrums not as frequent, less intense. I have better understanding of what my child's experiencing. Conclusions. So this case series, it highlights substantial improvements in children's symptoms and parental confidence and relationships through interventions primarily directed at parents. These findings suggest that enhancing the relational environment could be an effective strategy for addressing mental health disorders. So in the future, we are recommending 12-week training program for educators to do in school-based settings. And we anticipate remediation of trauma effects, reduced mental health issues, hospitalization, suicidal ideation, overall prescriptions of medications, and overall improving mental health, resilience, and academic performance will require formal subject research necessitating IRB. So that's all